Thank you, Mr. Chairman. Good afternoon, ladies and gentlemen. It's always a pleasure to be between my lovely Egyptian colleagues and people. As you know, functional endoscopic sinus surgery is minimally invasive and well-tolerated procedure. However, because of the close relation between the paranasal sinuses and vital organs, it carries the possibility of serious complications. Proper understanding of the anatomy, as well as careful preoperative radiological evaluation are essential to avoid such complications. Anatomical variations, nasal polyps, and revision surgeries are variables that commonly interfere with the proper surgical landmark identification and possibly increase the risk of such complications. Hypoplastic maxillary sinus is one of these variations. It's uncommon in normal population, with incidence of 2% to 10% have been reported in the literature. But we don't know what's the true incidence in functional endoscopic sinus surgery. Basically, it's defined and occur when the lower margin of the maxillary sinus not exceeding the nasal floor. MSH classified by Bolger in 90s according to the CT findings, which considers the status of the ansenet, the infundibulum, ossimetal complex, and orbit into 3 classes. The first one is when the ansenetic process is normal and the infundibulum is normal. Class 2, when the ansenetic process is absent or hypoplastic, as well as when the infundibulum is ill-defined. And class 3, when there is no ansenetic process, no infundibulum, and the maxillary sinus is like cleft. Now, if you review the literature about the outcome of endoscopic sinus surgery in hypoplastic maxillary sinus, we will find few case reports and some small case series of small numbers of patients, and these advocate that medical therapy of hypoplastic maxillary sinusitis is usually ineffective and functional endoscopic sinus surgery is the treatment of choice. But what is the outcome of FESS in these patients? To answer these questions were our objective, so we did a retrospective study, single surgeon experience of almost 10 years. We exclude patients with facial trauma, congenital facial deformity, tumors, or bone destruction. We defined improvement according to the recent cohorts, so patients with no symptoms or symptoms which are not impacting the daily life, plus objective evidence of patent maxillary sinus ossia, either by endoscopy or CT, were considered as improvement. So we found hypoplastic maxillary sinus accounts for 5% of all endoscopic sinus surgery. The average occurs in 3rd to 4th decades, with a slight gender of female prevalence. A total of 54 maxillary sinus were detected in these 38 patients. It's bilateral in 50% of cases. And when we divide the cases according to the class, we found that the majority are in class 1, and I will show you why. These patients presented with non-typical sinonasal symptoms. The majority of them presented with more than one symptoms, and nasal obstruction and headache were the most common presentation. It's frequent to find middle turbinate variations, accessory extralamellar variation with these people With nasal septal deviation to the ipsilateral side is the most common reported variant. Now, what about the surgical approach? Now, we have three problems when dealing surgically with these patients. The first one, as we said, the high prevalence of middle turbinate and incident variations. The second one is the laterally displaced medial maxillary sinus wall. And third, the obliterated infundibulum, as well as the orbital content close relation. The best to divide these people into types, how to approach them surgically. So type 1, we can approach them as usual, but we will need to follow closely the anatomy. And the best way is to do the antrostomy just above the superior turbinate and below inferior turbinate, and just below the inferior lateral attachment of the polla. This is a very safe place. Whereas in type 2 and type 3, it's best to do posterior frontal antrostomy and extend this anteriorly. Don't worry about circulation, simply because these people, they don't have a natural maxillary osseum. And we found also it's very helpful to do some additional techniques and maneuvers to do safe dissection. We use navigation in 4 cases. In other cases, we use inferior antrostomy lavage or temporary inferior antrostomy to suck the thick fluid inside the maxillary sinus. Complications, no major complications were reported. We have one patient who we need to winding the ostia, which was fibrosed in the clinic. The other patients were found to be disease-free. Now, in literature, the term chronic atelectatic maxillary sinus, silent sinus syndromes, as well as hypoplastic maxillary sinusitis-related sinusitis have been used confusingly. For the sake of time, just please try to remember this table. So, hypoplastic maxillary sinusitis in the 3 stages, I think it's fit within stage 2. Chronic maxillary atelectasis, whereas silent sinus syndrome is the end stage of chronic atelectatic maxillary sinus. And also, try to remember also that the nasal symptoms, there was reverse correlation between the nasal symptoms and the class level. So class 1 or stage 1 hypoplastic maxillary sinus is usually symptomatic, whereas the silent sinus syndrome usually presented with no sign of nasal symptoms, as you know, and is present with mid-face or orbital deformity. To conclude, maxillary sinus hypoplasia is uncommonly encountered in elective contralateral sinus surgery for CRS. FESS is safe and effective procedure in these patients. However, the surgeon should carefully consider the variation in the lateral nasal wall and tailor the procedure according to the preoperative CT scan and intraoperative endoscopic landmark findings. Additional techniques during surgery can be helpful to properly identify the suitable surgical dissection field. I think my time is up. With these beautiful pictures in the spring in Jordan, I will stop.